morning, everyone. We're going to get started. Welcome to Grand Rounds. Today, we are so lucky to have Dr. Delphine Tuot, who is the division chief in the Department of Nephrology and also a professor of medicine at UCSF. Today, Delphine is going to share all her expertise on managing CKD, which is so important to us as primary care HIV providers. And her talk is called Filtering the Facts, Updates in CKD Management for People Living with HIV. Thank you, Delphine.
Great. Thank you so much for inviting me. First off, should say I have no disclosures. I forgot to put that slide in, so I apologize. And also just want to preemptively thank one of my colleagues, Michelle Estrella, who's a professor and the division chief at the VA, who has much more actually content expertise in HIV. And so I stole some of my slides from her. But I will say that most of what we're talking about today in terms of updates are going to be non-specific to HIV, because most of the recent updates in CKD management have really skewed towards non-HIV mediated and more towards traditional causes of chronic kidney disease and management. I would just also today just want other take-home messages. I'll repeat this slide at the end, but risk of risk of kidney disease depends on genetic predisposition, degree of viral control among your population, ART regimens, which we will not get into today, and really comorbid conditions and how to manage those. And so the overall approach to treating kidney disease, both screening, monitoring, and treatment, has really evolved to be more proactive and risk-based. And there are now many drug classes available for the management of CKD. And hopefully by the end of this talk, you'll feel more empowered to use some of them in your primary care HIV patients. And I will say, if there are any questions along the way, please feel free to raise your hand, shout out, and hopefully if you're on the Zoom, Liz will let me know as well. So feel free to jump in. Okay, so let me start. Why should you care about kidney disease? One, patients with kidney disease have higher risks of heart disease, hospitalizations, AKI, AFib, stroke, early death. All of these you can see in this figure here from the most recent KDIGO international guidelines suggest that the risk of all of these bad outcomes increase as your GFR declines. And this is true for all of these as well as just in general cardiovascular disease. So this is true for your patients as well. CKD is also a silent killer, right? It is asymptomatic. Most people are not aware that they have chronic kidney disease and so don't necessarily participate in healthy lifestyle habits to curb their risk of chronic kidney disease and cardiovascular disease. Studies suggest that even people with stage 3, 4, 5 CKD with a higher risk of CKD progression to end-stage kidney disease, only about 40% of those individuals know they have kidney disease. Presence of CKD has implications for drug selection and dosing, and prevalence of CKD is actually high in the general population at about 13% in the United States, and it's also high among people living with HIV, and this is a recent figure from a review earlier this year that suggests that in North America, that percentage is about 7%. So what are the main risk factors for development of CKD among people living with HIV? So this is our first case. So this is a 50-year-old male with a rapidly progressing kidney disease and proteinuria. You can see the dates on the bottom. This is a very old case back in 2008. His baseline creatinine about 3 months prior to this was 0.9 milligrams per deciliter. And then in February, sort of rose up quickly to 2.6 milligrams per deciliter. And then about a month later, skyrocketed, right? So this is an individual who has untreated HIV, a high viral load, history of skin popping, has diabetes and hypertension for a modest amount of time. What's the most likely cause of his kidney disease? I think this is a poll. My hope is perfect, thank you. So is this diabetic nephropathy, acute interstitial nephritis, minimal change, HIV, or AA amyloid? Awesome, so all of you very correctly and astutely identified that this is probably HIV-associated nephropathy. I will say diabetes, minimal change, and AA amyloid are also causes of nephrotic range proteinuria, which we'll get to in just a second, and should be on our differential. But the fact that this was very rapid rise of creatinine and proteinuria in somebody with uncontrolled HIV suggests that this might be the most likely HIVAN. HIVAN is a collapsing form of focal segmental glomerular nephritis. You can see here, this is the glomerulus that is completely collapsed within Bowman's capsule. Same is true here. These are the path slides that we see and really portends very poor prognosis in terms of progression to end-stage kidney disease. This affects individuals of African ancestry most exclusively, but it is essentially preventable and reversible with HIV suppression, which is why this case is so old. We don't see much of this anymore. But I bring this up for a couple reasons. One, to just highlight that the differential diagnosis for nephrotic range proteinuria is much wider now because you have ART and because you're treating your patients so well. So whereas a decade ago, I would have said this is HIVAN and nothing else, now there are other possibilities. And actually most of what we see are other forms of FSGS, focal segmental glomerular sclerosis, largely because you're treating the HIV. And so this is what we call sort of partially treated or previously treated HIVAN. You can also have drug-induced causes of proteinuria, adaptive proteinuria from hyperfiltration, which we see in patients with obesity, hypertension, obstruction, and then genetic causes, which I'll get into in a sec. Other etiologies, minimal change, membranous, AA amyloid, which we see in our patients quite a bit, which are individuals with chronic inflammation because of recurrent infections, is actually quite common. And lastly, but not least, advanced diabetic nephropathy. So again, the reason why I brought this up is one, to identify other causes of nephrotic range proteinuria, and two, to just bring up this concept of genetic etiologies of chronic kidney disease. So we are gaining our appreciation of both monogenic and polygenic etiologies of chronic kidney disease. And so one of those genes I just want to identify here, which of the following genes has been associated with HIVAN? Is it UMOD, ApoL1, sickle cell trait, or GST-M1? Note that all of these genes have actually been implicated in kidney diseases, but only one has been associated with HIVAN so far. Great. So excellent. So ApoL1 is in fact the gene that has been associated and confers a higher risk of HIVAN among African-American individuals. So as many of you may know, ApoL1 encodes apolipoprotein L1, also known as the trypanolytic factor. This ApoL1, we believe, we don't exactly know the true function, but it creates a channel, we think in the podocyte, which provides some innate immunity to trypanosomes. Over time, the trypanosomes then developed this SRA, the serum-resistant associated protein, which prevented lysis. And then over time, genetically, we then developed genetic variants of ApoL1 to combat or to counteract the serum resistance associated protein. And so we have a G1 and a G2 variant of ApoL1, which then confers additional immunity to the trypanosomes, but increases our risk for FSGS, HIVAN, and just in general, faster progression of CKD in non-diabetic patients, including individuals living with HIV. But there is considerable heterogeneity and susceptibility of CKD among individuals carrying these G1 and G2 alleles. So while we think approximately 13% of the African-American population in the US has two high-risk alleles, thus giving them high risk of chronic kidney disease, not everybody gets chronic kidney disease with those two high-risk alleles. And so this idea of a two-hit hypothesis for ApoL1 related kidney disease is both true among individuals living with HIV and individuals without HIV. And so this idea is that you have your high-risk genotype, either homozygous for G1, homozygous for G2, or heterozygous, you see G1, G2, and you have some modifier, whether that's a gene modifier or an environmental modifier, which then will lead to that second hit and lead to albuminuria or kidney function decline. We haven't found a whole lot of gene modifiers yet, but there are some very clear environmental modifiers, including HIV viral load and Hep C treatment. So I just wanted to offer some data from a study from Michelle Estrella back in 2015, really highlighting that viral load and suppression or treatment of HIV can really help mitigate the risk associated with high-risk alleles. So these are These are participants of the MAX cohort, and they essentially categorized individuals either being unsuppressed viral load or suppressed viral load. And the suppressed viral load had a pretty stringent definition of a viral load less than 400 copies for 95% of their follow-up time. And you can see here on the left that among individuals who had unsuppressed viral load, those with a high risk alleles of APOL1 genotype progressed much more quickly. The y-axis is predicted GFR progressed much more quickly than individuals with low risk APOL1 genotypes. But among individuals with suppressed viral load, so well-treated HIV, those risks of eGFR decline were actually quite similar. So while we can't change someone's genetic makeup quite yet, we do have things from an environmental standpoint that we can do to slow risk of CKD progression. I also want to highlight additional research and exciting new developments in this field. Some of this was actually highlighted last week at the the Society of American Kidney Disease Kidney Week. And there were some more abstracts about inaxaplin. And I don't know if many of you have heard of inaxaplin, but it is a small molecule inhibitor of APOL1. In preclinical mouse studies, it actually impeded or inhibited the APOL1 channel that we think has developed on the podocytes and reduced proteinuria. So last year, they had a phase 2A open label clinical study just among 13 individuals who had 2 high-risk APOL1 genotypes or genes and had FSGS on biopsy and substantial proteinuria. And among those individuals, they had a single once-a-day pill of inaxaplin and followed them for 13 weeks. And you can see here from the graph, it's only 13 individuals. One individual at 13 weeks had higher proteinuria than when they started, than the baseline, but everybody else had a much impressive change in proteinuria thanks to this single drug. Overall, it was about a 48% decline in proteinuria over those 13 weeks. And so thanks to this, there is now a much bigger randomized control trial. We're actually enrolling folks. This is based out of UCSF Health. My colleague Mian Park is involved. And I think right now we've had 2 patients from our renal clinic involved in this larger study. So we're continuing to enroll and genetically test individuals who have a propensity for this. So exciting new things. Say that again. Correct. So there are 2 ways. So the question was, how do we refer patients essentially to this? We have a fast track, obviously, because we work very closely with our patients over at UCSF. What I recommend is to send them to us in renal clinic. We can do the testing ahead of the genetic testing in our clinic and then determine if they are a good candidate. We could also, if individuals don't want to come to clinic, refer them directly, but they do need to have a biopsy suggestive of FSGS at this point, which is why most of them will come from renal clinic to begin with. So definitely another reason to send people our way if they are predominantly African, if they are African American, or you think they may have 2 high-risk genotypes and have proteinuria. So we just talked about how good viral load can decrease the risk of CKD progression, even if you have genetic predisposition. But really these days, the main causes of kidney disease among individuals living with HIV have shifted from HIV-related factors and co-infections to really non-infectious comorbid conditions. So your classic etiologies of kidney disease: diabetes, obesity, cardiovascular disease, malignancy, et cetera. And so the underlying etiologies that we will see will be much more heterogeneous than we had seen previously. So let's talk a little bit about this. Given this complexity, how do we best assess kidney health among individuals living with HIV? So this is a 45-year-old female who was diagnosed with HIV, would like to initiate ART. I don't need to tell you, but these are the most recent guidelines. I didn't see any recent updates for kidney testing in patients living with HIV. So in general, there's consensus that you get a basic metabolic panel at baseline, and then after ART initiation, and then every 6 months after that, and at least a UA at baseline to check for proteinuria and hematuria. The IDSA would also recommend potentially a UACR, urine albumin to creatinine ratio, as an alternative to a UA. And I hopefully will encourage you that that is the better approach in the next couple slides. So which of the following is correct about blood tests assessing kidney function? One, serum creatinine-based eGFR equations yield the most accurate GFR estimates. B, accuracy of GFR equations is higher or better at higher levels of kidney function versus lower levels of kidney function. C, serum cystatin C is not available at ZSFG. And D, GFR estimates are inaccurate during AKI. So which of these is correct? Great. Okay, so most of you correctly identified D. GFR estimates are inaccurate during AKI. And so let me go through the next couple slides. We'll explain why the top 3 are incorrect. So as many of you know, just backing up in 2021, new creatinine and cystatin C based equations to estimate GFR were released after a large task force spent 2 or 3 years really identifying new equations that did not include race in their as one of the variables, because as many of you know, race is not a biologic factor. And so the bottom line of this landmark publication in the New England Journal was that addition of cystatin C to creatinine generally yielded most accurate GFR estimates when compared to measured GFR using iohexol. This looked at the data that led to this was using the CKD Prognosis Consortium, which is a huge international group that uses 21 cohorts of just both individuals at risk for CKD and in the general population, as well as individuals with CKD to develop these types of equations. And importantly, there were a few cohorts that did include individuals living with HIV. So this is quite pertinent to us all. So let's talk about both of these, creatinine and cystatin C. So there are clear scenarios where serum creatinine may be misleading, right? You all know that creatinine is generated mostly from muscle mass, can also come from high protein diets. And so when folks are elderly, when they have amputations and don't have the same muscle mass as they may have otherwise, malignancy, HIV, cirrhosis, all of these may be conditions where serum creatinine is a little bit lower. And so therefore, the elevated GFR that comes with that serum creatinine in the equation may be falsely elevated. There are also conditions where serum creatinine generation is high, and so the GFR will be lower and will be falsely low. This is among individuals with large muscle mass, or weightlifters, or young individuals, meat diets, and protein supplements. There are also many medications that can elevate serum creatinine. Many of those are part of ART. And so as you know, certain medications, as I just said, can increase serum creatinine levels without changing kidney filtration. So this is actually a beautiful renal tubular epithelial cell. And you can see that creatinine on the basolateral side is taken up by cells through the organic cation transporter, both 2 and 3. And then it's then secreted into the urinal lumen using the MATE1 transporter. And so you have certain ARTs that block creatinine uptake by the cells, and also some that block creatinine secretion. Because of this, serum creatinine then rises, but that does not mean that their kidney function is any worse than they were before you started these medications. And these medication effects can be actually quite large. These are data from 2020 in one particular trial, I don't remember which one, but that showed that, for example, cobicistat and dolutegravir could change your median GFR by 13 to 16. That's actually quite sizable, right? And so it's just important to be aware of these. Those changes usually stabilize about 2 weeks after you start your medication. So often we'll see somebody just with a lower GFR 2 weeks later, but that doesn't mean that their filtration is any worse. Which then makes you think, well, maybe serum cystatin C is the way to go, and I should only be checking serum cystatin C. That's also not true, actually. There are characteristics of cystatin C that make it a great marker for kidney disease. It's produced by all nucleated cells constantly, 24/7. It's freely filtered at the glomerulus, and it's completely metabolized by the proximal tubule. This would make it a really good marker for kidney function. But it is also elevated in states where you have more cell replication and more division. So this includes states of inflammation, smoking, heart disease, obesity, cancer, use of drugs or use of steroids in particular. So also not perfect, which is why we tend to use the combination when possible of both cystatin C and creatinine. And I'll mention that in a second. The other thing to remember that the E in eGFR is estimate. These are estimates of glomerular filtration rates, and it's really important that you don't take them for an absolute gold standard measured GFR. You must recall that there is a relative large margin of error, particularly among individuals with higher GFRs. So for example, here at this dot, this is an eGFR of 60, the estimate, but the true GFR could be as high as 75 and as low as 40. That's actually a pretty wide range. Thankfully, for most of what we're doing, that range is actually perfectly acceptable. However, if you're using medications that have a very narrow therapeutic window, this is why trying to use both cystatin C and creatinine to get closer to that measured GFR is helpful. And also trending people's eGFRs over time tends to be more helpful. And also just a quick plug, these equations assume constant markers, constant levels of both creatinine and cystatin C, which is why eGFR in somebody who has an AKI is just not that helpful. So what should we do? One, I'll just say that the adoption of that 2021 race-free equation for both creatinine and cystatin C is now very widely adopted across the US, across all of our campuses as well, and then LabCorp and Quest. So that's a good thing. Cystatin C is now available at all 3 UCSF campuses, which is also great, and they're all in-house. It is still, however, substantially pricier than a creatinine. And so I take that in mind right now when I'm ordering either creatinine or cystatin C or both. And so my approach, this is not necessarily perfectly data-driven, but my approach right now is when I have a clinical scenario where I'm not sure, I'm not convinced that the creatinine is accurate, then I will check a cystatin C at the same time. And then I will calculate, there are equations that we can use to calculate the eGFR, the estimated glomerular filtration rate, using both creatinine and cystatin. And then I document that difference with my eGFR creatinine in my note, but I follow creatinine because it's so much cheaper than repeating a cystatin C and a creatinine each time. I will say that I'm starting to check cystatin C yearly in my patients because there are new data to suggest that the difference between eGFR creatinine and the eGFR creatinine cystatin, if that changes over time, that actually provides additional risk for ESKD decline. So I'm starting to incorporate more cystatin C, but I will say it's still about 10 times the price, which is why I don't do it all the time.
Is there an epic tool that we can plug in to calculate that and do better?
Yes. So the question was about epic tools to help us with these calculations. So there is a dot phrase, I think .sys, CYS, and that'll actually give you the combination of creatinine, of the eGFR using creatinine and cystatin C. It does not give you the diff yet. And I'm still chatting with the lab right now about including, if you do order a creatinine and a cystatin at the same time, to get a row in our results that actually show the combined eGFR. That's going to take a little bit more programming, so I'm hopeful that that's going to be a 2025 addition to our lab reporting, but it is coming. Okay, so now that we've talked about serum tests for kidney disease to identify and manage chronic kidney disease, how do we go from there? And so this is case number 3, 65-year-old with long-standing HIV, hypertension and diabetes, well-controlled HIV, sees you in clinic. He's been on multiple ART regimens in the past, but is now stable with an undetectable viral load. Long-standing hypertension and diabetes, which are decently, but not perfectly well controlled. Serum creatinine is 1.6. So which of the following is correct? A, he does not need additional workup for that elevated creatinine of 1.6. You think this is likely just diabetes, hypertension, you don't need to do anything else. His risk of developing ESKD outweighs his risk of cardiovascular disease. He should undergo CKD testing with eGFR and UACR, or he should undergo CKD testing with eGFR and a UA. Perfect. So I agree. He should undergo CKD testing with eGFR and UACR. So I just want to take a step back here. Screening versus testing for chronic kidney disease. Screening for chronic kidney disease is still quite controversial in the United States, right? In 2012, the USPSTF clearly stated there's no role for screening for chronic kidney disease among adults without risk factors who are asymptomatic. But it's very different for asymptomatic individuals to be, and those without risk factors, versus testing for CKD among individuals with risk factors. Both ACP and the USPSTF have clearly stated that testing for kidney disease among individuals with risk factors is perfectly appropriate and should be done. And so conditions of CKD risk that they identified included diabetes and hypertension, which are the most common causes of end-stage kidney disease in the US, as well as cardiovascular disease, family history of CKD or some genetic predisposition, and then AKI history. This was reaffirmed by the 2021 KDIGO International Kidney Guidelines and Recommendations that, again, conclusion one was that you should be testing for chronic kidney disease in all patients with hypertension, diabetes, and cardiovascular disease. They additionally came to a second conclusion that identified that testing for kidney disease among individuals with other important risk factors, which could include environmental exposures or other comorbidities, including HIV and viral hepatitis, was their second conclusion. This is a little bit further than what the USPSTF had said previously. And then conclusion number three, however, is we don't really have data on how often we should be testing these. Should it be yearly? Should it be more than that? And really we should be individualizing those decisions. Also this is an international professional society, so also depends on your ability and your resources and high level or high income versus low income countries. I will also say the USPSTF is currently reevaluating their previous recommendation about screening for kidney disease in the general population because of all the new medications that are available, which I will talk about. I personally don't think they're going to say screen everyone in the general population, but again, individuals with increased risk include all of your patients, so we should be testing. And we should be testing using both blood, which we just talked about, and urine. And so this is just my 2 slides about how important urine testing and urine albuminuria quantification it is for all of our patients with risk for chronic kidney disease. And UAs, while they can be quite sensitive for high levels of albuminuria, so albuminuria over 300 milligrams per gram, they are not sensitive for individuals with lower degrees of albuminuria. Sensitivity is anywhere from like 42 to 50%, which is really unacceptable. So we should be using urine albumin to creatinine ratio or urine protein to creatinine ratio if there's a concern for non-amyloid proteins or non-albumin proteins, such as if you have amyloid in your differential or drug toxicities, because those really affect the tubules. Albuminuria is a glomerular protein.
Just a logistical question. So we frequently get first screen urines for STI screening. Is there any concern about sensitivity or changes in the urine protein creatinine? I know that's not, we do clean catches if we're doing a sort of UA in culture, but what about for the?
I don't think so. In general, we tend to recommend actually first morning. So the question was about first morning voids or just initial stream for STI screening. I see. Yeah. Clean catches are better. I don't know the data, specifically the data offhand, but I would say any is better than none. So many of you know this heat map. This heat map came out in 2012. It's been a little bit updated since, but essentially this is a very crude prognostication for cardiovascular disease, end-stage kidney disease, all those bad outcomes we said in that first slide, based on both GFR and albuminuria. And why I really like this picture is because you can see very clearly here that an individual with, say, a GFR of 50 with 0.5 gram of albuminuria has the same relative risk of end-stage kidney disease than somebody with a GFR 15 or 16. Now, obviously, these are crude buckets, but just to show the importance of albuminuria testing to quantify risk among our individuals with chronic kidney disease. So don't forget the urine. This is a busy slide, but I also just want to say that albuminuria I find is also helpful to try to determine etiology of kidney disease. CKD right now is a bucket diagnosis, right? We look at this and we say it's a lab test, it's GFR and albuminuria, but that doesn't tell you where the lesion is. It doesn't tell you how to manage the underlying problem. And so proteinuria or albuminuria can be helpful. These are not mutually exclusive categories, but you can see going from the left to the right. If you have somebody with what you think is purely a vascular etiology of their kidney disease, so hypertension, renal artery stenosis, they tend to have much less proteinuria, with little to basically nothing, up to about 1 gram a day. And then as you move down this list here, if you have cystic diseases, tubular interstitial diseases, and finally glomerular etiologies of your kidney disease, you're gonna have a lot more proteinuria. So this obviously is helpful for us in the renal clinic, but may be helpful as you're trying to think, should I refer this person to a renal clinic or not? Get an albuminuria and see where they are roughly on this spectrum. Which then brings me to when should you refer to us? Always when you're not comfortable is what I will say. I'm on the other side of that e-consult, hopefully with friendly responses, but we prefer to hear about these patients early to better identify whether they should be seen in kidney clinic or whether they can stay in your clinic with some virtual co-management. So if the underlying etiology of CKD is not clear, please send them our way. If they have severe kidney disease, GFR of less than 30 or high levels of albuminuria, or, which I'll talk about in a second, an elevated kidney failure risk equation, which takes into account both GFR and albuminuria. Rapid CKD progression, which is greater than a sustained progression of greater than 5 mils per minute per year. And then, of course, all the other usual suspects, hematuria, acid-base abnormalities, resistant hypertension, et cetera. Bottom line, whenever you're not comfortable. So let's talk about the KFRE. Hopefully, some of you have heard about KFRE. KFRE and EPIC will pop up your 2-year and 5-year risk of end-stage kidney disease. KFRE just uses albuminuria, sex, age, and GFR and gives you this predicted risk. It's actually a really nice patient-facing website as well, with lots of very clear pictures and describing your risk of end-stage kidney disease. I like KFRE for 2 reasons. One, because it really helps patients decrease their anxiety when they see their low GFR, and you can tell them, actually, because your albuminuria is low, your risk of end-stage kidney disease is like 2% over 5 years. That, if they see it on a website, makes them feel so much better than when I tell them in real life. So I find it's really helpful for individuals at low risk of end-stage kidney disease, as well as individuals at high risk, to try to encourage them to engage more with us in care. So .KFRE. And individuals, I will say, with a 2-year KFRE of greater than 3 or 4% is totally valid to send them our way. But the truth of the matter is that risk of end-stage kidney disease is much less than risk of cardiovascular disease in our patients. And so most of our work these days, and what I want to talk about for the remaining sort of 20 minutes or so, are all the new medications that are for treatment of kidney disease, really are treatment for cardiovascular disease in our patients. And this includes, this slide is the latest figure, an overarching figure from the KDIGO guidelines earlier this year, released in February of this year. And so we can talk about ACEs and ARBs and blood pressure control with a target systolic blood pressure of 120. SGLT2 inhibitors that I want you to start and continue until they reach end-stage kidney disease. We'll talk about that in a sec. And if you haven't heard about these, I want to introduce two-ish newer, I should say, drugs for kidney disease progression and for cardiovascular disease. This includes non-steroidal mineralocorticoid receptor antagonist. Finerenone is the one that's available right now in the US. And then many of you I've seen have used GLP-1 receptor agonists for treatment of diabetes in your patients. Think about it also for treatment of chronic kidney disease. And so we'll get into that. So you all use ACEs and ARBs. We know ACEs and ARBs are good. And what I would just want to use with this slide is to really encourage you not just to start your ACE and your ARB when someone has proteinuria, but to titrate it up to its maximal dose as long as they still have proteinuria. Our goal with those ACEs and ARBs are 1, blood pressure control, and just as importantly, minimizing your albuminuria. This is an old study from China that I really liked because it was one of our earlier indications that minimizing albuminuria is helpful in our patients. So this study randomized 360 non-diabetics with a moderate, like a healthy amount of chronic kidney disease to either standard benazepril or losartan, or titrated up to their maximal doses as tolerated. And you can see here that the primary endpoint was actually much lower in the 2 groups with titrated benazepril and losartan to the highest dose. And this was independent of blood pressure control. The titration really was because of albuminuria minimization. And that led to a 50% decrease in risk reduction of the composite endpoint, which was a kidney endpoint. So ESKD, doubling of serum creatinine, or death. So please titrate your ACEs and your ARBs. Everyone always asks, well, how much GFR change are you okay with when you titrate these medicines? In general, I'll say a 20 to 30% rise. If someone rises dramatically, sort of recheck and then send them our way. Maybe they were volume depleted. Maybe they have underlying renal artery stenosis that you're just uncovering now, and there are other things that we can do. Most of the time, their GFR will then settle with that second check, confirmatory check of creatinine.
What's your endpoint there? Is it independent of blood pressure? Do you push it until they can't tolerate it anymore? Like, what do you, what's your goal?
What's my goal? Yeah. So the question is, what is our goal with titration? Our goal is 1, that they're not hypotensive, 2, that they're not hyperkalemic, and 3, as low albumin as you can. So really our goal, we're titrating to albuminuria here and just trying to minimize side effects. That is true of all this next group of drugs that I'll be talking about.
Do you have a preference for ACE or ARB drugs?
I don't, because we are often regulated by formularies. I tend to use what's on the formulary. I will say in the past year, I've used more telmisartan because it has that longer half-life. And that I got from a collaborator and colleague from UPenn, who's a hypertension expert. And so she's a big proponent. So I've been using that more and more just because of the longer half-life. But I can't say in my minimal ends that I've seen a difference yet.
Is that cheap and available?
It is available. I don't know about cheap, but I will say I haven't had any issues in our Medi-Cal patients. Yeah, so the question about telmisartan in particular was that the half-life or using it daily as opposed to BID. Like for example, losartan has a pretty short half-life. It really should be a BID med. Whereas telmisartan, the half-life is actually 22 hours. So you can really use it daily. Individuals with pill boxes, it's just easier to take. That's exactly right. The other reason to use ACEs and ARBs and any of your other armamentarium for blood pressure is blood pressure control. We should be targeting a systolic blood pressure of 120, right? Sprint came out in 2016 with the CKD subgroup out in 2017. Sprint, as many of you remember, randomized over 9,000 individuals to a target systolic blood pressure of 120 versus a target systolic of 140. It was stopped early because there was a mortality benefit of individuals with lower blood pressure. This also importantly for us included a healthy subgroup of individuals with chronic kidney disease. Our worry was that if we targeted a lower blood pressure, we would really push people over the edge and into ESKD earlier. That just simply did not bear out. We did have slightly more AKI events once you targeted that lower blood pressure, to be expected, but over time, the rate of eGFR decline was actually lower in the individuals that were in the intervention arm. So we should be targeting a lower blood pressure. Now, I will say Sprint didn't achieve 120. Their actual achieved blood pressure in the intervention arm was 124 millimeters of mercury, but the point is to try to target a lower dose as much as possible. There's always, or a lower blood pressure. There's always a question in the renal division among our colleagues, what blood pressure do you check? Is it ambulatory? Is it office, et cetera? I think ideally it would be a research level blood pressure, someone sitting in a chair for 5 minutes, their arm raised in a quiet environment. That's not always possible, obviously. I will say home blood pressure readings tend to be more accurate than in the office blood pressure readings. So I personally tend to target home blood pressures if patients can come and show you their readings at home. And again, be aggressive. I have become much more aggressive in the last couple of years. So you've now started your ACE, you've titrated your ACE, you're aiming for good blood pressure control. Now what? For individuals with residual albuminuria, regardless of diabetes status, and any individual with diabetes should get an SGLT2 inhibitor. As many of you know, SGLT2 inhibitors prevent glucose reabsorption and thus sodium reabsorption in the proximal tubule, which then leads to more sodium and more glucose kind of going down the nephron, leads to glomerular tubular feedback and lots of great side effects, which were completely unanticipated when these were developed. And so the results of many of these pathways will lead to both cardiac and renal protection. There are so many studies that I can't show them all, but I just this is a slide showing the first 4 big studies and their main outcomes. So EMPA-REG, Canvas, and DECLARE-TIMI had cardiovascular endpoints. And you can see in each of these scenarios, the SGLT2 inhibitor, whether it was canagliflozin, empagliflozin, or dapagliflozin, led to lower cardiovascular disease. Kidney disease was a secondary endpoint in each of these trials and was also positive. Credence was the first trial that was actually powered for end-stage kidney disease or a kidney outcome as their primary outcome and showed the same thing. This has now been replicated with all of the different SGLT2 inhibitors, and so I think this is largely a class effect. But I do want to highlight that this slide was presented last week at our National Kidney Meeting, and I thought was actually really instructive. So you've started your ACE and your ARB, you've added your SGLT2, but if someone has residual proteinuria, they are still at risk of kidney outcomes. And so this was a nice retrospective analysis of the DAPA CKD trial, which is another really large trial looking at kidney disease as its primary outcome. They did DAPA versus placebo on a background of ACE and ARB. So everybody had an ACE and an ARB. Over 4,000 patients. So dapagliflozin reduced albuminuria in similar proportions among individuals with and without diabetes. The absolute reduction of proteinuria was higher among patients with diabetes because they started with more proteinuria, but the relative risk reduction was actually the same. And importantly, that was a mediator for outcomes. And those with residual albuminuria, so this graph is looking at individuals with UACR at month 4, so after they've had 4 months, regardless of whether you were on the DAPA arm or the placebo arm, if you had residual proteinuria, your hazard of end-stage kidney disease or your kidney disease endpoint was still higher. So really just additional data to suggest that the issue here is albuminuria. We need to protect the tubules from this albuminuria that's coming through the glomerulus. And so however we can reduce your albuminuria even after an ACE and an SGLT2 inhibitor is what we need to be doing. This figure is showing the hazard ratio for kidney endpoints. It was exactly the same when they looked at cardiovascular endpoints as well. So in the last 10 minutes, I just want to identify and share with you 2 different and new classes. I'm not sure if you've used any of these medications before, but non-steroidal mineralocorticoid receptor antagonists are now 3rd line, I would say, to further reduce albuminuria and cardiovascular risk among individuals who have diabetes, HFpEF, or HF with mildly reduced ejection fraction. The cardiovascular group that's missing here is HFrEF, because in those individuals, a steroidal MRA, so notably spironolactone, is still gold standard, right? That is a 1st line sort of class 1A recommendation for individuals with HFrEF. It very well may be in the future that finerenone or the non-steroidal may show equivalency in those patients, but we don't know that yet. So the big differences between those 2, you can see that the molecular structure of finerenone is a little bit different. It doesn't have all of these steroidal rings. It is a bulky medication with very good specificity and potency for the mineralocorticoid receptor. And importantly, compared to spironolactone, which has a huge half-life, finerenone has a very short half-life. So spironolactone is great in some ways, because if you stop taking it, you still have residual effects about 4 to 5 days later, because all of the different metabolites of spironolactone actually still have a potency against the mineralocorticoid receptor. That's not true of finerenone, which actually doesn't have any known active metabolites. So it's a quick acting medication. It is still daily at this point. I was surprised that it wasn't a BID med based on this half-life, but it's still daily at this point. And we think because of this short half-life is the reason why it does not have the same properties of spironolactone in terms of hypertension. So it's not a good hypertension med, or cause of hyperkalemia. So it doesn't cause that same hyperkalemia that we see in our patients with kidney disease with spironolactone. And so how does it work? It affects, just like spironolactone, it affects the mineralocorticoid, the binding with the mineralocorticoid receptor. It's a selective antagonist, essentially, binder. And as a result, you end up with improved endothelial function, less fibrosis, and less immune activation. So there are a lot of studies going on right now looking at the immune phenomenon related to cardiovascular and kidney health, and blocking the mineralocorticoid receptors seems to improve that inflammatory milieu, if you will. And so you end up with less cardiorenal damage. These are just studies of the pooled analysis of the first two big studies looking at finerenone among individuals with diabetes and kidney disease. So this was on a background of ACEs or ARBs. They had over 13,000 adults with, again, CKD and diabetes, had a potassium of less than 4.8. So while finerenone doesn't cause the same degree of hyperkalemia that we see with spironolactone, it still is a modest side effect. And again, these individuals were without any reduced ejection fraction. And you can see here that among the composite cardiovascular outcome and the composite kidney outcome, finerenone on top of an ACE or ARB led to decreased of those outcomes. So certainly positive. Newer studies were just recently released last week as well, which also suggested reduced cardiovascular and kidney outcomes among individuals with mildly reduced ejection fraction, regardless of diabetes status. And then lastly, consider your GLP-1 receptor agonist. I've seen many of you use the GLP-1 receptor agonist for treatment of diabetes, for treatment of obesity. Consider it a renal drug as well. So the FLOW trial was just recently released. FLOW looked at semaglutide versus placebo, again, on top of an ACE or an ARB. About 94% of patients were already on an ACE or an ARB before they started the semaglutide. These were all individuals with diabetes with a mean GFR of about 47 and a mean UACR of about 500, despite their ACE and their ARB. They had a mean A1C of 7.8% at baseline. Again, FLOW was stopped early at a median of 3.4 years due to efficacy, and the efficacy, their main outpoint was a major kidney disease event, which included all of these events. You can see here in this very clear curve that semaglutide led to a lower hazard ratio for this major kidney event. And when they calculated number to treat, it was about 20. So 20 people with diabetes and residual proteinuria would need to be treated with semaglutide to prevent one major kidney event after 3 years. So that's pretty impressive. And so the question is now that we have these drugs, ACEs and ARBs, SGLT2 inhibitors, finerenone with other non-steroidal mineralocorticoid receptor antagonists coming, and our GLP-1 receptor agonist, I think the question is, in which order should we be using these medicines? I think if we go back to, this slide, first line therapy really at this point is still ACE, ARB, and SGLT2 inhibitors. Start your SGLT2 inhibitor when someone has a GFR of over 20 and don't stop it. Even if their GFR goes down, we don't stop it until they reach dialysis, if they choose dialysis as their renal replacement therapy. I will say, I suspect in about 2 to 3 years, we will be continuing these patients on SGLT2 inhibitors, even while they're on dialysis, in a very similar way that we're continuing ACEs and ARBs. We just don't have those data yet, and those trials are underway. So definitely use these two as first line. And then as a second line agent, if someone has residual proteinuria, my choice is either adding finerenone or adding a GLP-1 receptor agonist, depending on their degree of diabetes control, whether they're obese, et cetera. So just think about the other side effects, but they both reduce albuminuria quite effectively. Okay. Excellent. So I'm right on time. So my take-home points again, going back to our very first slide, is that individuals living with kidney disease have really skewed towards non-HIV mediated etiologies of kidney disease. We still see our high vans, we still see ART mediated tubular toxicity, but you're going to see a lot more diabetes, a lot more hypertension, a lot more of the other idiopathic causes of kidney disease. So it behooves you to be just aware of those. Risk of kidney disease now depends much more on genetic predisposition that we are appreciating more and more. We talked a lot about, or a little bit about ApoL1, but there are lots of genetic kidney diseases that we're now gaining appreciation for, and we have access to genetic testing in our clinic, which is actually really nice, free of charge for our patients. Over our overall approach to identifying kidney disease, please don't forget the urine when you're testing for kidney disease in your patients. So a UACR and a blood test to check for estimated GFR. When possible, I would recommend at least once every year to check a combined or check both creatinine and cystatin, but not to do that every time because of the price of cystatin at this point in time. And remember the KFRE to think about prognosis of someone's risk of kidney disease. And if that KFRE, so .KFRE in EPIC, if that KFRE is greater than 3% at 2 years, feel free to send them our way. And then lastly, management of kidney disease is really management of cardiovascular disease. They're all intertwined in this kidney cardiometabolic entity that we're seeing largely in our patients. This includes ACEs and ARBs, which you know very well. Titrate that up to maximum tolerability, SGLT2 inhibitors, blood pressure control, and then try to feel empowered to start finerenone or a GLP-1 receptor agonist in our patients. Both are covered by Medi-Cal. And that's it. Thank you so much for your time. I really appreciate it.
Thank you, Delphine. That was fantastic. So much high yield stuff for our practice. Questions from the audience? I can get us started. Go ahead.
This is more just a thank you. I just wanted, in case people don't know, interacting with Renal Clinic on eConsult is fantastic. And I've found that a lot of the cases that we present don't need to be seen in Renal Clinic, but you and your team always give a nice algorithm that we can then follow. So just in case people haven't done that, I've done a lot of those. So
thank you. That's really kind of you to say. I mean, a lot of kidney disease is lab-based. And so, yes, we can do a lot of management virtually. And so feel free to send those e-consults our way if you have any question. I will also say that doesn't mean we don't need to see folks, right? We get a lot, or I get a lot of satisfaction out of spinning someone's urine. It does give me extra data, actually at least once, to see us in clinic, and then we can send them back your way once we feel comfortable with etiology of kidney disease. So a volume assessment and a urine spinning to me is still gold standard, but definitely there's a lot that we can do virtually, especially if you have questions about any of these new medications. Are they indicated? Are they not? I had 3 consults last night about use of SGLT2 inhibitors, not in patients with HIV, but just is this person indicated and are they not? What should we do?
Can I just ask a question related to SGLT2 inhibitors? What has your experience been with the tolerability? I found people have had the issue with, urinating more, urinary tract infections, and then you're stuck with, at least with one of them has a black box warning for diabetics that you have an increased risk of having a foot amputation, which people have said to me, I don't want that. And I totally get it, but we're sort of stuck with that. What do you tell them and what's your experience been?
Yeah, so the one for the foot infection is still canagliflozin, I think, right? I think, yeah. So I tend to use just GAPA or EMPA as that very simple trade-off right there. And of the other 2, there are individuals who do have increased urinary frequency and are symptomatic from it. The trials do not bear out that there is increased risk of UTI on the population level. There is a slight increased risk of fungal urinary infections, which I do warn people about. And so I'm careful about individuals who might have unstable living situations or may have a harder time practicing good hygiene. In those patients, I may be a little bit more cautious. So what I will do is I will tell them they may have urinary frequency, try to bear it out. And if it's not possible, then I stop it, right? It's all individualized risk assessment. In those individuals, many of our patients, before we start SGLT2 inhibitors, will also be on a diuretic. I'll often stop the diuretic and see if that balances out some of the urinary frequency that they may be experiencing. Oftentimes that does the trick, though not always.
I have a question. I think generally just our patients have so many comorbidities and CKD is diagnosed on lab and urine. And so any pearls you have on like explaining it to folks and also sort of gaining people's buy-in to adherence for these multiple interventions. I feel like that's a challenge in primary care.
It's a challenge in our clinic too. So yes, thank you for asking. Yeah, so CKD is asymptomatic. People don't tend not to care about it, but they do care about dialysis. And so not that I want to scare people, but this idea of you can reduce your kidney risk and improve your cardiovascular risk using this one medicine, right? And so that's the type of approach that I tend to use. I talk to people about the 2 lab tests that we like to use because they can see it on my chart. They can trend for those that are interested, a GFR. And importantly, you can tell them it's supposed to vacillate. It changes a lot. A change of 30 to 25 or 45 to 40, that is okay over time. But look, we were able to decrease your albuminuria by X amount using this medicine. That is huge. And that's what I focus on. And then I will say in terms of burden, like one of the issues is that the more meds, more polypharmacy. I've been trying to use combination medications as much as possible. They are not available yet with a lot of these newer drugs, although I will say there are some SGLT2 combinations, though I have not had success in getting them covered, but I have had more success in covering combinations for blood pressure meds. So if I'm able to take away a blood pressure medicine, then I'm able to add an SGLT2 inhibitor, add finerenone as an example, and that's the trade-off I'm talking to people about.
So I found that ambulatory blood pressure monitoring can be helpful for titrating the blood pressure meds some, but it's been really hard to access. Do you have any tips or tricks from Renal Clinic in getting that for our patients?
Not yet. Thank you for asking. We do not yet have an ambulatory blood pressure program at ZSFG. They do have it at UCSF. We're thinking about trying to start one, so more to come. But I also think just even without ABPM, just home blood pressure checks 3 times a week, 3 mornings a week can be just as helpful for titration.
All right. Thank you so much. That was fantastic.
Thank you.